Well, kind of the last part of this podcast that I want to talk about is transcranial magnetic stimulation therapy (TMS), and you're a neurologist, but this is really kind of like a new hot issue in psychiatry. Even though I think it was FDA approved in like 1995 or something,
Mhm.
but this is potentially a treatment for depression and for individuals who have really not found a good therapy that's working all that well for them. I know you have some TMS machines in your office. I really loved that experience, getting to learn about these machines and talk to the patients that benefited from them. So, kind of, can you tell us about like how TMS got started?
Um, well, from my understanding, it was actually, and believe it or not, that's the reason why neuro and psych are in this on the same board because there's a lot of crossover.
Hmm.
Because ultimately, how you behave is how your brain functions, and so there's the crossover. And again, sorry, another side story. Even when they came out with the MEG, which is the magnetic encephalogram, which is the basically a combined EEG with MRI.
Okay.
It basically allows you to see your brain waves, not just only on the surface of the brain, like the EEGs,
Hmm.
but this penetrates throughout the whole entire brain.
Okay.
And so, there's not a lot of these machines, and there were where I went, the university I went had was one of the places that originally created it, or part of it. So they had an animal version and an adult version,
Wow.
right next to each other. So it's pretty amazing stuff to learn. And guess what? It wasn't used by neurologists that much to do research because we kind of already know the structures of the brain and what it did. Most of the research on the MEG were people like you who are in psychiatry that wanted to figure out was there anything more um, uh, objective to pinpoint any of the causes of psychiatric diseases. So, funny enough, a lot of the MEG studies were all based on were more psychiatric than anything else, right? And again, TMS is the kind of the crossover of the two, and um, how it was eventually developed was because of the MRIs and because of the studying of psychiatry and because of the studies that were done. People were getting routine MRIs, and even though they figured out that there wasn't anything on the functional MRIs that could diagnose depression, because depression is a constant fluctuation of your certain activity of particular areas in the brain. Um, it fluctuates. It's like people are not always depressed. So it's not
Yeah.
like they could just measure a marker and say, hey, look, that's
Hmm.
diagnosis of depression, right? Because they could be happy 1 minute and which then the levels are up and then the serotonin levels are up and then they'd be sad again and the serotonin down. So it fluctuates. So there's nothing on that allows them to use that to diagnose. But what ended up happening was because people who participated got so many MRIs, most of them started feeling better anyways. And therefore they realize that in treating MRIs, basically is just a big magnet. And but as you know, a magnet creates polarity. And if as the med students know, or healthcare, they know that brain works on electricity, right? Electricity works on positive and negative ions that exchange through the membrane to create a pulse. So if you think of it, how the TMS works is basically creates a magnetic field where it allows that distinction of that positive and negatives to separate to then create a pulse, to then excite the neurons to then create create its effect. And that's how the TMS technology was born.
Okay. And kind of my understanding of the theories of how this works, is kind of threefold, and I'd love to kind of hear your opinion and kind of guide my learning. And
Sure.
so, you know, uh it possibly, like, that magnetic field can increase some of the blood flow into the brain, and maybe this is having some sort of positive effect on depression. Maybe it's increasing both blood and spinal fluid into the cranium. Another theory that I kind of researched is potentially it's increasing metabolism in the region stimulated. I know the machine you have in your office, it targets the dorsal lateral prefrontal cortex, which is kind of an area for regulation of behavior, appetite changes, sleep changes, energy level changes. And then the last is potentially it releases kind of a slew of neurotransmitters. So we're
Right.
not exactly sure what's going on, but do you have any theories? Do you think one theory is stronger than the other of why people are benefiting from this?
Um, no, I think, to be honest, I think it's a combination of all of it
Okay.
because, and I'll try to explain that. Obviously, the, you know, dorsolateral part of the frontal cortex is part of the limbic system that regulates our behavior, right? And it's all interconnected, right? And it basically allows release of all the different types of neurotransmitters, not just the serotonin or like what the some of the antidepressant drugs target, but the dopamine, the norepinephrine, the epinephrine. So it targets everything and basically overexcites the whole system in itself to release all of that, and that will help you regulate um, your behavior just by exciting the limbic system. So in that sense, it will help in treating depression. Now, going to the circulation thing, it absolutely will also cause that because we have iron in our blood, in our red blood cells.
Mm-hmm.
So again, it's a magnet. So iron is magnetic. So if you're turning on a magnet in your brain, guess what? It's going to suck up blood into your head. So that increases flow to your brain overall, and even more to the area that you're focused on if it's a focal magnet. And so therefore supplying that area with blood, which then increases the energy it supplies, right? And also so it will further promote the excitability, I guess, of
Mm-hmm.
that region. And so um, and CSF is just a product of the blood, not so much so CSF,
Okay.
you know, because of you know, yeah, never really thought about the CSF part, to be
Okay.
honest.
But maybe
But
because it doesn't have that, like, kind of ion component that wouldn't be as impacted by the magnetic field. Okay.
yeah, so so yeah, I think it's definitely a combination of the two, and it's
Okay.
not the one thing because the even though it's a focal magnet, you have to understand that it's a system of that is throughout the whole head, right? It's
Mm-hmm.
your midbrain, it's your frontal cortex, it's single gyrus, loops all the way around, includes to your temporal lobes, to your memory. So it excites all of that, and therefore, you know, it's it's trying to raise that baseline, and that's the reason why you need the repetitive amount of treatments because it prompts your brain to keep up at that same baseline.
Okay.
If that makes any sense.
Yeah, yeah, and just so the listeners kind of understand, Dr. Lee kind of touched on. So my understanding of TMS is that you would be going daily for about 4 to 6 weeks. More about is that what your practice looks like with TMS?
It's actually 6 weeks
Okay.
and a weaning period of 3. And so it's
Okay.
daily, or not daily, but 5 days a week for
Okay.
first weeks, and then the next week every other day, and then the 8th week is 2 in a week, and then the last week is just 1 treatment. And you know, does it have to be that? The answer is no, but that's what the protocols that the research and the FDA approval was done, and that's how it's passed. So you kind of have to go by that.
Yeah.
So,
Yeah.
but it just reinforces the idea that should be daily, and it's not a long treatment. It's only in treating most average only about 20 minutes.
Yeah, yeah, and the setup in your office I thought was just awesome. These patients would be kind of sitting in the chair with like the TMS machine over their head. I'll post a photo on Instagram of a TMS machine, not yours. But then there was like a big television screen, and people would be watching YouTube or Netflix, kind of just really enjoying themselves.
Yeah.
So
Yeah.
what kind of patients should potentially consider TMS therapy?
I'll be honest. Um, all patients are depressed,
Okay.
which is a lot of people. But you know, again, this is the how our system doesn't make any sense because you know a lot of the insurances will want usually regulate a failure of certain like anywhere from 1 to 4 antidepressants before they will approve this treatment for the patient.
Okay.
And so, you know, but my personal opinion is that why take a pill when you have something that's non-invasive, with very minimal side effects, you know, versus taking a pill that could potentially have more.
Mhm.
Just saying, you know.
And something that a pill you'd have to take every single day, whereas this is something 6 weeks. It's not necessarily forever.
Yeah.
But I guess here's where I'm a little confused. Do some people use TMS as that's their only treatment, or and also some people use it kind of in conjunction with medication they're already on?
So the idea of the treatment is that whatever you're already on, we stay because if you play around with your meds during the time after the treatment of the TMS or during the treatment of TMS, you might cancel out the effects.
Okay.
For example, if the TMS is working for you and helping you with your depression, but then you decide that you're going to take off a medication and that made your depression worse, then that just canceled it out. And then
Mm,
you didn't, you come out not feeling like anything's different. So our protocol is to have patients stay on their meds at least for the next year, unless there's some, side effects or some other thing that absolutely requires them to be off of a certain medication, then that's fine. But in general, if we're doing a TMS and we want to see how well the TMS is working, we try to have the patient stay on the same meds um, throughout the treatment and even past that to a whole year if possible. And that's also how the research was done. And 50, I mean, the success rates are pretty incredible. I mean, much higher than any pill out there,
yeah.
right? I mean, the numbers is pretty much looking at 67 to 80% in reducing major depression down to mild or none, right?
Hmm.
Versus what first pill is in the 20,
30%. Yeah.
yeah,
Yeah.
30%.
It's
You fail
terrible.
that, it's half that. You
Hmm.
fail that again, by the fourth, you're down to 1%.
Yeah. Yeah, it's
So
it's it's really sad. It's really unfortunate, and I hope that TMS can be like a wonderful kind of like intervention that hopefully we can use. So, what what side effects do patients potentially experience going through TMS?
well, the most common side effects is a usually in the first week is headaches, and that's understandable because we just talked about migraines and
Hmm.
how blood rushing to the head causes headaches. Well, if the magnet's pulling the blood into your head, guess what? It's going to cause headaches. So the way we try to counter that is that when the treatment's going on, we have you breathe out. So when you breathe out, you collapse your lung, and then that opens up the heart bigger so that
Oh, okay.
the it drops the blood pressure out of your head, so it counters that pull in, so it minimizes that. But usually your body adjusts really quick. So we also suggest that some if people are getting some headaches, they might want to take a NSAID or Tylenol, Advil
Hmm.
right before the treatment. But that's only usually required in the first week. After that, they get so used to it, they don't
Okay.
even they don't get headaches anymore, and they don't need to take anything anymore. So
Okay, rad. And so kind of another thing is I guess who shouldn't use TMS therapy? And kind of my understanding of it, at least now, it's quite frankly someone like me, someone who has a psychotic episode before. I had a manic episode about 10 years ago, or maybe if you had some elements of psychosis. Some certain types of depression do have psychotic features. So if you do have anything like that, you're not appropriate for TMS, correct?
In theory.
Okay.
But see, that's what the research have shown, and in theory that makes sense. So if you understand the idea is that it's exciting the brain. Well, when you're in a manic episode, your brain is overrunning.
Hmm.
It's you know, and so if someone has a tendency to allow the brain to overrun, guess what's going to happen if you're exciting the brain? You might actually trigger that manic episode.
Hmm.
So in theory, yes. Have, have we treated patients that has had manic episodes? Yes. And we warned them about it. They told them, but and they actually did fine, and they actually were did help. So, because again, you have to understand that your brain waves are not static. It
Hmm.
fluctuates. Your brain activity fluctuates. So it's not like, you know, am I going to go treat someone while they're in the midst of a manic episode? No. But, but you can understand why that is one of the, well, it's considered one of the contraindications for the insurances. But,
Okay. But it could
again,
still, of course, be considered. Like you
then,
touched on.
right. And then obviously, again, the other obvious cause is any metal in the head.
Hmm.
So
Yeah.
because of the magnet.
Yeah, that one's at least absolute. They're definitely not going to do it. Yeah, that respect.
But
Well,
that's pretty much it.
yeah, I did a whole presentation actually at my school on TMS and ECT, electroconvulsion therapy, and there's such a negative stigma around ECT. However, it does work,
Yep.
and in my limited research, ECT actually works a little bit better than TMS. They both have positive effects on depression, but ECT can potentially have a little bit more profound of an effect. However, one thing that TMS does not have is like all the negative memory kind of loss impacts that ECT potentially has. And you don't need an anesthesiologist. In my understanding, it's a much less cost to the patient and to the health system as a whole.
Absolutely. And like I said, it's not as invasive and not as dangerous, not even dangerous, I would almost say,
Hmm.
you know, um, versus the ECT. But yes, you're absolutely right. Does ECT work? Yeah. I mean, it's, the research have shown it. So
Yeah.
that's why it still exists. So,
But I mean, to even find, I mean, here in Yakima to get an ECT provider, I think you'd have to go all the way to Spokane or all the way to Seattle. To my knowledge, there's no one that does it in this area.
no.
If you are in the Central Washington area, I hope you would consider visiting Washington Neurology. I think your clinic is just awesome, and look into TMS and the other services that you provide. Dr. Lee, thank you so much for coming on the show. You've talked to me for over an hour. This has been really awesome. I've really, really enjoyed this. Is there anything else you'd like to share with our listeners?
No, no, no. It was my pleasure, and it's I love what you do, and I love how you guys are innovating healthcare and doing stuff like this and getting the word out and educating the public, which is what doctors are supposed to do. So,
Mhm.
you know, yeah,
Yeah, I
very
get.
proud of you, Logan.
Well, thank you very much, Dr. Lee. And you provided me obviously with a letter, a tangible thing, but as like a role model who I emulate to be like, once I finally graduate residency and hopefully have my own clinic. I hope TMS is one of those things that really becomes commonplace. It's in like every primary care clinic in the nation, because every single family doctor is treating countless amount of people with depression. So
Hmm.
hopefully we just continue to see this rolled out further and further and further, because I think it can have so many wonderful impacts for people.
Same here.
Yeah.
I believe that too. So Got to change the healthcare system first, though. But it
Yeah,
starts with you guys.
yeah, yeah. Hopefully, hopefully.